think are the barriers to expansion of medication-assisted therapies in federal and state prisons?
I think that it does relate to a culture that we observe in many of the treatment programs that rejects the use of opioid-assisted therapies as medications because of the belief that you're changing one drug for another, when in fact we know that they are very, very different, and they are therapeutically beneficial and cost-saving.
So, Mr. Botticelli, after a life is saved from an overdose by naloxone, people with chronic addiction need to be linked into effective, ongoing treatment for their conditions. I understand that you were instrumental in Massachusetts in helping to increase access to medication-assisted treatment programs within community health centers. Do you believe this model, the Massachusetts model, can be used to expand access to these therapies across the country?
I do. You know, one of our challenges is how do we continue to expand access without building bricks and mortar? And our federally qualified health centers are uniquely situated, both in rural areas, to really look at doing that. And we found by giving minimal assistance to federally qualified health centers, we could increase by about 10,000 the number of Massachusetts residents who were able to get very effective, comprehensive medication-assisted treatment with the rest of the services that they needed.
Dr. Clark, do you agree that expansion of medication-assisted therapies into primary care settings such as community health centers would be helpful?
One of the things that we supported at SAMHSA is integrated treatment, which would include federally qualified health centers. The other thing that we would support is the transition from the criminal justice system back to the community using medications like naltrexone, which buys both the addict and the community enough time so that the person can re-engage in follow-up treatment. What often happens is the person uses shortly after being discharged from the penal facility, and then they overdose. So if we could have naltrexone administered, injectable naltrexone administered prior to discharge from those facilities, we would have at least a month time to engage in a federally qualified community health center or a substance abuse treatment program or an opioid treatment program that would be using naltrexone to help facilitate reentry into the community.
Thank you. May I continue?
You go ahead. If you
Okay, please. Thank you, Madam Chair. Dr. Volko, I'm kind of surprised at how remarkable it is that we have so few medications available to treat addiction. I'm concerned that our desire to find treatments that completely eliminate drug use may keep us from finding treatments that will reduce drug use or reduce the harms associated with drug use, harms like incarceration, family instability, difficulties holding a job. What do you think is needed to further the development of treatments that reduce drug use or related harms?
Well, it's unfortunately a paradoxical situation because we have a disease that has a tremendous impact in terms of morbidity and mortality. The science is that has identified several potential targets that, if developed, could be beneficial for the treatment. And yes, we do not have the interest from the pharmaceutical industry in developing medications for a series of reasons that have been delineated on a study done by the Institute of Medicine. And one of the recommendations is how to incentivize the pharmaceutical industry in order for them to invest in the development of medications. The targets are there, and you have a condition that actually is chronic. So one of the arguments that they would not be able to recover their investment is not even correct. And the Institute of Medicine went further because they actually identify ways that the government could incentivize pharmaceuticals without it costing a single dollar to the government. But they have not been implemented.
And if I may just ask one final question, of all of the prescription opioid painkillers prescribed in the world, of 6 billion people, 90% of them are prescribed in the United States. 4% of the population of the world has 90% of the prescription opioid painkillers. So what does that tell us about the United States? What does it tell us about our society?
I think that the numbers speak for themselves. I don't think that we can argue that we have much more severe chronic pain than other countries. I think that the numbers are telling us something very clear. We are overprescribing. While at the same time, it does not negate that we are not necessarily properly treating patients that suffer with chronic pain.
Yeah. So I thank each of them for their tremendous service, but At the end of the day, there's one thing we can't do, and that is pass a Good Samaritan law. I think thousands of people's lives would be saved immediately across the country because people would not be afraid then to just inject someone or to give them the help that they need for fear that they'd be sued if something went awry. But we know that most people would just thank God that the fear is gone. And I think firefighters across the country, policemen across the country, they'd all be more willing just to rush in and just apply. Because if you do it in a timely fashion, you save the life. Then you need to deal afterwards with what happens to the person. Do you have a bed for them? Do you have the treatment for them? Huh? But at least you've kept them alive. Huh? And then we have a responsibility subsequently. We don't have either right now. And until we put both in place, then I think this problem is just going to continue to escalate. Thank you, Madam Chair.
Thanks, Senator Markey.